Okay, I see you raising your hand. Oh, wow. We got a few panelists.
Hola.
Hey, how you doing, Khalif? How you been?
I'm good. Hola. ¿Cómo
Good,
estás?
good,
¿Cómo
good.
estás?
Muy bien. Ah,
Muy bien.
okay. Sí, más tarde hay un charla en español.
Ah, no español.
¿Dónde está? Tú estás en España ahora, ¿verdad? Tú estás en...
Poquito.
Where are you? Are you in Spain now?
I am in Valencia.
Oh, God, beautiful town. I was just there a couple of months ago.
Beautiful place, I tell you. Beautiful place.
Yeah, beautiful place. You look like you're in the lab now.
Yeah, I'm in the lab, yes.
Okay, very good. Okay,
Yeah.
well, we're going to learn about neuromodulation. I don't know much about it, so...
Yeah.
So, hello, Georgios. Georgios is here. Georgios, are you there? Hello, Giorgio. Let me unmute you there. Whoa, we got a few people here. Hey, it's going great, Khalif. It's going great because
Wow.
I'm meeting with a big pharmacy company from Mexico.
All right.
That's interested in getting involved.
Wow.
You know, because pharma and medicine have always been associated with education.
Yep.
So that's just the game. That's just the way it goes. And so it's going well.
That's very good, man.
And we like to have them help do stuff like get a lab in Nairobi, get a lab all set up and everything.
Lots of potential, man. Lots of potential.
Hello, Georgios.
Hello, good morning.
Good morning. I'd like you to meet Khalif, a neurosurgeon from Africa, from Nairobi. He's now in Valencia, Spain.
Nice.
In Valencia. It's Valencia, John. It's Valencia.
Valencia with a soft C.
Yeah.
Well, George speaks a couple of languages. What, Russian, German?
Oh, Russian.
No, Russian. Not Russian, only Greek, English, German.
Я русский знаю, по-русски чуть-чуть знаю. Я учился в России.
This is the next step.
Yeah, yes, good. How is Greece?
Well, Greece is a lovely country, but I'm in Germany now.
Oh, you're in Germany.
Yeah, Cologne, right?
Cologne, right.
At the University of Cologne.
Right.
Are they pretty connected, the university, with the internet, and they do some stuff, a lot of stuff?
Actually, no.
No? Okay.
Because
we haven't had many German neurosurgeons join us. I don't know, whatever.
Stress, there are many of them here.
Yeah.
Real many of them.
Well, we'll get to them. We'll make it. They'll get tired of running from us.
There are many orthopedic surgeons as well.
Oh,
yeah.
okay.
Oh, yeah. Well, this platform can be used for anything. Any matter of fact, in Mexico, we're going to try to develop all specialties online to have similar type of broadcasts.
Mm-hmm.
I mean, there's no borders on the internet. There's no borders. It doesn't matter what country you're from, just as long as you have internet access. Okay, do you want to go over the screen sharing? Do you remember how to do it?
Let's try it.
Yeah, let's. There you go. Okay.
I think you can see it.
Yep.
Yeah, I can see it.
And
You
now
can see
you can see it.
Yeah, it's good size. Right. It's good size. Okay.
Here as well, I think.
And if I remember correctly, you had videos or no videos?
I had one or two videos. I have one or two videos, and the sound is
Okay.
active.
When you don't forget to play the sound when you know what I mean, when you start screen sharing.
Let's see.
Yeah, go back to the starting the screen sharing.
No, I activated, but can you hear it?
Oh, okay, good. So you must have it marked.
Good.
Yeah, you must have it marked. So.
Okay.
Very good. And I'll get you off the screen, okay, to start, to introduce you and everything. I'll get you off the, let me
We've got 10 more minutes.
Yeah,
John.
yeah, we got 10 minutes.
Yep.
I hope you had enough sleep. It's 8 o'clock in the morning there.
Oh, yeah, this is wonderful for me. But I've been up since 4, so I like to get up early. And plus, it's easier to communicate with India and that part of the world.
Okay.
Late at night for me, but that's the best place to connect, time to connect.
Okay.
Europe is not so hard, but when you connect with a country like China that's 12 hours away, you really got to alter your schedule. And you got to change your thinking about what time it is at that place. So
Internet is perfect, but the time zones is a problem.
well, I'm glad to see we have a couple of people I don't even know, which is great. Maybe they're from the neuromodulation community. And we'll go around. Can the participants all hear me? Khalif, you know, Lexi, Leandro,
Yeah.
Dr. Chirag, Marlena, are you there? All there? Okay.
Yes.
Yeah, welcome. We're gonna, if you don't mind, we're gonna introduce you at the start. Okay, everybody. All I want you to do is basically say who you are and your interest in neuromodulation, and that's it. Just like, you know, part of the value of medical meetings, as you guys know, is meeting people and expanding your network. So we can also do this with this platform. Right, Dr. Chirag, how you doing? Welcome.
Yeah, thank you very much. I'm fine.
Yeah, great. Welcome.
Yeah,
Okay.
Thank you very much.
Okay, you know how to, everyone knows how to mute. You got to keep conscious of the mute button.
Yep.
Because obviously, like Dr. Chirag did, he unmuted himself and spoke. And then after you finish speaking, please mute yourself. Otherwise,
okay.
Otherwise extraneous sounds attract the camera. In other words, if you make noise, it'll go to you. So when the speaker is presenting, it's distracting. So okay, Marlena and Lexi.
Yeah, can you hear me?
Yeah, Marlena, your camera's not working. I don't know what's going on there. At the very, are you on a smartphone, Marlena, or?
Yeah, on my phone, yes.
Yeah, well, at the bottom of the screen, there's a camera icon. You need to just tap that. You see at the bottom of your screen, it'll have a camera. You'll have a microphone and a camera. You got to turn the camera on. Do you see it?
Not yet.
Okay.
Well, I can see you, but
Yeah, it's just
okay. Is it okay now?
Yeah, there you go. How you doing? There you go. Because we want to get to know you. In medicine, you don't go to meetings with hoods on. You go, you meet people and they see your face, and they get to know you. How about you, Lexi? Lexi, are you there? And you're certainly willing just to watch. If you don't want to take part, introduce yourself, that's fine. So
maybe he's not hearing.
It could be.
Yeah.
But certainly, I know some people just want to watch, which is fine.
Okay.
So yeah, things are moving forward, Khalif. It's going great. We just televised a conference from Madrid last week.
Yeah. Okay. Oh yeah, the stroke, the vascular symposium.
Yeah. Neuro interventional radiology.
Yeah.
Man, I love Madrid because I took the train from Valencia to Madrid.
Okay.
To
All
Madrid.
right.
It's like an hour and a half,
Yeah.
a 2-hour trip, fast. Man.
Yeah.
And right into the middle of Madrid. It's great. It's a great way. How are you getting back? How long are you staying?
I'll stay until March 10th.
Oh, March. You're there for a while.
Yeah, I'm going to be here for a while.
Wow, like a fellowship, right?
The train from Madrid to Valencia.
Now, it's not a conference there now. You're just doing some time with
Yes,
Dr.
yes.
Gonzalez. Are you with Dr.
Some Dr. Piquer, Jose Piquer, and Gonzalez next month. But there's going to be a conference in March, Neuroanatomy 3D.
Yeah, I'd like to get that. We've kind of lost communication, Dr. Gonzalez, because I'm sure he's busy as heck.
He's quite busy, I think, preparing for the conference. So I'll get there next month. I'll keep you updated.
Yeah. Anything he needs to televise. Actually, I've talked to him, texted and talked to him, but I haven't really had a video chat with him.
Yeah.
He's busy as hell, but yeah, certainly we're open to televise anything that he wants to televise.
Yeah, the healthcare system in Spain is very nice.
Yeah, it's. I've never seen. But apparently people really like the neuroanatomy 3D.
Yeah.
So it's a platform. What is it like? It's a program, right?
Yeah, it's a program that Dr. Jose Piquer has organized with the College of Surgeons of East Central and Southern Africa. It's an exchange program of 2-3 months, which we come here and see how they work and learn from them and go to the lab. They've got a lot of specimen. I just got a new specimen I'm working on. So it's a very nice place.
Oh, good.
Yeah.
So you're going to be at that hospital for a month and move over to
Gonzalez for another month and then prepare for the.
Oh wow, that'll be great.
It's a lovely thing.
That'll be great. Now is he based in Valencia, Dr. Gonzalez, or Barcelona?
It's Valencia, but he's in Alicante. It's one of the districts of Valencia.
Right. It's next door, right?
Yeah, it's not very far. It's like maybe 1 hour drive or something like that from main town, Valencia. Yeah.
Okay. Review. Oh. And chronic pain. Okay. Yeah. So yeah, Khalif, we have the webinar in about 3 hours from Africa.
Another one?
Yeah, from Africa. We have 2 presentations and 3 hours from now.
All right.
But we got Giorgio now, so Giorgio's. Okay, you ready? Almost ready, Giorgio's?
I am ready.
Okay, let me just put my background to look professional. Hold on. Where the heck is it? Okay, I'm just going to get you off the screen share, Giorgio, so I can introduce you. Okay. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. We're pleasure with the presence of Georgios Matis, the MD from originally he's in Cologne right now, and he'll tell us about his background. But let me first introduce the panelists before we turn it over to Georgios. Okay, Dr. Chirag, could you please introduce yourself?
Hi, everyone. Actually, I'm from India. I'm Dr. Chirag Solanki, and I'm a practicing neurosurgeon, and I'm doing neurosurgery practice for last 5 years or so. And uh, I have done my fellowship in functional neuromodulation surgery from Oxford, UK, under Professor Tipu Aziz. And that is why actually I'm interested in this functional neuromodulation stuff. And in India, in the place where I'm staying at present, in the state of Gujarat, I'm going to introduce this neuromodulation surgery. And next month, we are launching the program for neuromodulation surgery.
Oh, great,
So
great.
It's nice to have you all here for a fruitful discussion and to know something more about functional neuromodulation surgery from Dr. Georgios.
Yeah, me too.
Yeah.
Hi, Marlena. Could you please introduce yourself?
Hi, I'm coming from Greece. I'm not a surgeon. I'm into histology and neurophysiology. So it's I'm interested in a scientific point of view.
Oh, great. Very good. Welcome, Marlena.
Thank you for the invitation.
Okay, George Carmani, are you there, George? You have to unmute yourself, George, if you go ahead. Go ahead, George.
Yeah, hi. Can you hear me?
Yes.
Perfect. My name is George Carmaniolas. I'm working for a company in this field, most scientific. So I am an active member. I have an active part in this therapy, and I am really excited working in this field, and I am looking forward to learn more and develop my knowledge in this area.
Great. Welcome, George. Lexi, I don't know if you're there. Are you there, Lexi? Perhaps not. And Khalif, welcome back.
Hey, thank you so much, John. My name is Dr. Khalif. I'm from Kenya. I'm a fellow in neurosurgery in the College of Surgeons of East Central and Southern Africa, COSEXA. I'm currently in Valencia, Spain, with Dr. Jose Piquer.
Yeah, hopefully we'll be following Khalif to find out about 3D neuroanatomy in the future, possibly. Okay, Georgios, welcome. And could you please say a few words about yourself before you go into your presentation, and welcome. Thank you.
Hello, everybody. Thank you very much for the invitation. My name is Matis. I'm coming from Greece originally. I'm currently working in Germany. I'm a neurosurgeon, and I'm working in the Department for Stereotactic and Functional Neurosurgery in the University Hospital of Cologne in Germany. I would like to speak to you about neuromodulation and chronic pain. If you don't have any questions, we could start with the presentation.
Okay, well, I think we're ready.
Sure.
Yeah, looks good.
Okay, so the topic is neuromodulation and chronic pain. When I first started working in this field, I didn't know what neuromodulation is. I thought it could be something like this. Later on, I found out that it is something a little bit more refined as that. So if you have interest in this neuromodulation field, you can visit the official website of the International Neuromodulation Society, neuromodulation.com, and there you can find many details about this therapy. But first of all, let's start with the definition. What is neuromodulation? It is defined as the alteration of the nerve activity through targeted delivery of a stimulus, such as electrical stimulation or chemical agents, to specific neurological sites in the body. There are many diseases which we can treat with neuromodulation. Among them are the movement disorders, Parkinson's disease, Tourette syndrome, dystonia, and many others, medically refractory epilepsy, pain, chronic pain or tumor pain, spasticity, urologic disorders, fecal incontinence, pelvic floor disorders, or gas disorders. So, an overview of the therapies which are associated to neuromodulation. There are many of them. We don't have to go through all of them, The most important are the spinal cord stimulation therapy, deep brain stimulation therapy, the intrathecal drug delivery systems, and now we have also the hypoglossal nerve stimulation, vagus nerve stimulation, the transcranial magnetic stimulation, and many, many other things. All of them with details can be found on this website. So let's concentrate now on chronic pain. We have, unfortunately, many chronic pain conditions, trigeminal neuralgia and different forms of headaches, as cluster headaches, leg pain, radiculopathies, back pain, phantom and stump pain, polyneuropathies, plexus lesions, angina pectoris, peripheral arterial occlusive disease, zoster and post-zoster neuralgias, complex regional pain syndrome with or without capsalgia, and tumor pain. Interventional pain therapy, we're working at the level of the first, of the second, and of the third neuron. At the level of the first neuron, we have the root stimulation, dorsal root ganglion, or DRG, the pulse radiofrequency therapy, PRF. We have subcutaneous leads or electrodes under the skin. This is the peripheral nerve field stimulation or the peripheral nerve stimulation when the lead is in the vicinity of the nerve. At the level of the second neuron, we have the spinal cord stimulation and the intrathecal opioid therapy. At the level of the third neuron, we have the motor cortex stimulation and the deep brain stimulation. I think you all know this World Health Organization lantern. I don't know if you can see the arrow moving on the screen. We start always with non-opioid drugs plus adjuvants. Then we go to weak opioids, escondane plus or minus adjuvants. And then the third step are the strong opioids. My mentor, Dr. Koulouzakis, has proposed another ladder, a modification of the World Health Organization ladder. We can start always with the non-opioid analgesics, but then we should try with the subcutaneous leads or the pulse radiofrequency therapies, then move on to spinal cord stimulation, and after that start working with weak and strong opioids. In the end, we have always this intrathecal opioid therapy, the pump therapy. Let's start with the stimulation of the dorsal root ganglion, or DRG. You can see on this picture 2 DRG leads with 4 conducts. The third conduct should be under the pedicle, and you can see also the loops for the leads so that we don't have any migrations or dislocations of the lead. This therapy is good for patients who have very good localized pain, foot pain, knee pain, or groin pain. Here there is, you can see a video, an intraoperative video. You can see the needle and you can see the lead coming out of the needle with the 4 contacts, which are coming under the pedicle. Our aim is to place the third contact under the pedicle, and then extremely slowly we pull back the lead, and we are trying to make this loop. This is for me the most difficult part of the operation, these loops, but they are necessary if we want to keep the lead in the correct place. This is T12 for a patient with groin pain, and after that, this is the lateral view. You can see the lead laterally, and now comes a second lead for the same size, but for L1 route. We don't have to see everything. The concept is the same for the placement of the lead. Pulse radiofrequency. What is that? This is a high frequency therapy. It's all about selective modulation of pain fibers based on ultrastructural changes of cell membranes. We stimulate 20 milliseconds, then we stop for 480 milliseconds. The frequency is 500 kilohertz. and we have a temperature of 42 degrees for 4 minutes. On the upper right, you can see a catheter, and the tip of the catheter, we can inject also drugs through this catheter. And on the right under, below the catheter, you can see a device, a generator, which is compatible with this catheter. Here we can see conus medullaris and all spinal roots. On the left side, the white catheter with the active tip. There are many ways to place the catheter in the spinal canal. This depends on the roots we want to influence. For example, if we want to stimulate, to modulate the sacral roots, we'll have to stay in the midline. So, sorry, the catheter can be placed this way, or in this way, or even in this way. This is the work of Dababu. It was presented in a radiology meeting 2018. I think it's really interesting. The title is CT-guided pulse radiofrequency, a minimal invasive procedure for acute, not chronic, acute radicular low back pain. 128 patients, PRF delivered directly to the nerve root, duration of the therapy 10 minutes, and 1 year outcomes. PRF was found to be superior to the steroid injection-only strategy. The perceived recovery, 95% for PRF versus 61% for injection. And the authors state that this temporary interruption in the transmission of pain decreases the local inflammation, and this allows the body to gently resolve the disc herniation. And the proof of it. So this is the MRI before the treatment. You can see the disc herniation on the left side, and you can see the image 1 month later. The disc herniation is smaller. This is an article published in the Journal of Pain Research 2018 with the title Prolonged Duration Pulse Radiofrequency is Associated with Increased Neuronal Damage Without Further Adialodinic Effects in Neuropathic Pain Model rats. So what the authors found is that when working with rats, they ligated L5 and stimulated in the vicinity adjacent to the L5 dorsal root ganglion. So white circle is some, and here with black is in PRF at 6 minutes stimulation and PRF with 12 minutes stimulation. So the authors found that we don't have any additional pain relief if we stimulate for additional 6 minutes. But they found that if we stimulate for a longer time, then we can have a neuronal damage. CRF, this is the continuous radiofrequency listening. Please have a look at this image. It's divided in 2 parts. The lower part is PRF, pulse radiofrequency. We can see here the colors are blue. Blue means that the temperature is not so high. The upper part of the image is CRF, the continuous radiofrequency listening. Here we have other colors. It is yellow, orange, or green. That means that the temperature is higher. The aim of CRF is to hit the nerves that conduct nociceptive stimuli. Examples are the medial branch of the dorsal ramus or the sacroiliac joints. We have an initial phase to reach the predetermined temperature, and we have a phase of maintenance, 60 to 90 seconds, with a constant temperature of 70 to 90 degrees. These are the needles we can use to do this CRF, or the instrument we can use for the sacroiliac joint. Intraoperatively, we see this thing. We have the needles, we have many cables, we have also drugs, and this is in everyday practice what we are doing for patients with back pain problems. In patients now with trigeminal neuralgia, we can offer this functional thermocoagulation. The concept behind it is that the pain-conducting fibers, or the C fibers, are less well myelinated than the other fibers. That means that they are more sensitive to heat. So under sedation and fluoroscopic control, we make a puncture via the foramen ovale with orientation points, the pupil, and the line between the external auditory canals. We make a testing with 2 Hz, the motor response of trigeminal nerve, and 75 Hz for the sensory. And when we are sure that we are in foramen ovale, we apply 60, 70, and 90 degrees for 6 minutes. Here is a video. You can hear the voice of Dr. Kouzakis, my mentor. He shows how functions should be made. You see that the patient is awake, open his eyes. You see the lead coming in. You see our old device here, lateral intraoperative image and anteroposterior.
Also wir fangen jetzt an, dann wieder schlafen lassen auf jeden Fall, weil das ist jetzt sehr schnell abläuft. Okay.
Ja. 70, 90
Auf! So.
But this is interesting. The testing with 2 Hz. You see that the jaw
Gut.
is moved.
Das. Und jetzt, okay.
This
Und
is
zu,
the
jetzt
that we are really in. PNFS, peripheral nerve field stimulation, the implantation of leads under the skin. Where should we put these leads? In the subcutis, over the muscle. Here we have epidermis, dermis, subcutaneous tissue. The lead is coming here, 9 to 11 millimeters under the epidermis. But this, of course, depends on the patients. An animation showing the placement of such a lead, we make the punction, and through this needle comes a lead with 8 contacts in the vicinity of the nerves. Then we remove the needle and the lead is staying at place. The target for this therapy are the cluneal nerves, the superior cluneal nerves or the inferior cluneal nerves. This is what we see with fluoroscopy in the operating room. And some examples of placement of these leads. One can place the leads parallel to the spine or perpendicular to the spine. This is what we see in the operating room. This is a placement of 4 leads. When I first saw that, I thought of this. It reminded me of trains. But this is a really good therapy for a variety of conditions. For example, genitofemoral neuralgia. Here we have a lead on the left side with 4 contacts. Here we have 2 leads with 8 contacts. Ulnar neuralgia, you see the IPG is implanted under the clavicle and 2 leads with 4 contacts here. CRPS, complex regional pain syndrome, 2 leads in the ankle region, and the IPG is coming in the thigh. We have scars, but we can make the best of these new scars with a little bit of imagination. We have many patients with neuropathic face pain. This example with problems in the second branch of trigeminal nerve, 4 contacts here, lateral and upper. This is a patient, a trial. We have implanted a lead for the second branch. The lead is fixated with sutures. This stays there for 1 week. After 1 week, the patient is coming back. We remove the lead, and the patient should tell us if he or she was satisfied during this trial. There are some patients with post-zoster neuralgia. We can place some leads in this area as well. Patient with occipital neuralgia. This patient here has two leads. The upper one is for his occipital neuralgia. The lower one is there because the patient had additional neck pain. There are many patients with knee pain. We can implant subcutaneous leads by these patients. There are patients with phantom pain. Subcutaneous leads can help. Patients with stump pain as well. The PNFS can be a good option. A pretty new option for chronic pain patients is the stimulation of the multifidus muscle. What is that? It is the stimulation of the medial parts of the dorsal ramus at the L3 level. Actually, what we are trying to do is to restore the muscle control, to rehabilitate the muscle so that the patients can go back to work. We implant two leads on the left and the right side and one IPGA, one battery. At the level of the second neuron, we have spinal cord stimulation and the intrathecal opioid therapy. Spinal cord stimulation, the target are the dorsal columns or better, the dorsal horns. We should implant leads epidurally with 8, 12 or more contacts, and then we should connect these leads to a battery, to an IPG. In addition to the segmental spinal effects, a supraspinal modulating mechanism is assumed via descending pathways. Currently, there is many papers on the possible mechanisms of spinal cord stimulation therapy. Nobody really knows how exactly this therapy is working, but it is working. It is an exciting field. This is what we see after the placement of the leads in the spinal canal with X-rays or fluoroscopy.
Participating in the procedure.
Animation showing the placement of the lead in the cervical area. We prepare the patient is lying down, we use local anesthetic, we should do a small incision, and then with a punction needle, we do the punction, we try to reach the epidural space. You see the angle of the punction is bigger as in the lumbar area because of the anatomy of the cervical spine, and then through this needle we can implant a lead in the middle line or on the left or on the right, depending on the symptoms of the patient. Then we stimulate in the operating room. The patient should tell us where he or she notices a tingling sensation so that we know that the lead is correctly placed. The same can be done for patients with back pain or back or leg pain. After that, the needle is removed and the lead is connected to external battery, to external IPG, and we test over the next days. In all countries, there are some guidelines about this spinal cord stimulation therapy. In Germany, our guidelines come from 2013. They are still active. It was decided from many societies that we should have some inclusion-exclusion criteria for this therapy. I think this is the same in all countries. Inclusion criteria are patients with chronic pain insufficiently treated with drugs or psychotherapy. Exclusion criteria are severe coagulopathies, mental disturbances, addiction problems, secondary gains. If the patients are having problems with an insurance company, it's not a good idea to implant such a system. Inability to use the spinal cord stimulation system, patients who are over 90 years old wouldn't be very good candidates for something like that. Advanced malignant tumor and infections in the area of implantation. According to the German Neuromodulation Society, the two best indications for this therapy are CRPS and failback surgery syndrome. Other indications could be angina pectoris and peripheral arterial occlusive disease. Although the German Neuromodulation Society says that angina pectoris is not the best indication for this therapy, we have many patients who benefit from it. And we can see here the placement of the lid at the level of C7, sometimes at T1, slightly placed on the left side. And they are satisfied, they stay satisfied for many years after the operation. The same for patients with PAD, we can implant a lead epidurally at the level of T10, the midline. And please have a look here at these images. Control, the color is green, blue. This is not good. 30 minutes after the stimulation, you see the color is changing. Instead of green, we have now a red. Red is good. A red means that more blood comes in this area. So the patients are getting more blood and the pain is reduced. We have many types of stimulation. The gold standard or the first type of stimulation was the tonic stimulation, a stimulation with a tingling sensation. After that, we developed a burst DR or burst-like stimulation. This is actually electrical impulses delivered in bursts to the spinal cord in quick succession. Why is this important? Pain has two pathways. The lateral pathway for the perception of pain, and there are papers who have shown that both tonic and burst stimulation or burst-like stimulation can influence the lateral pathway, but there is always a second pathway, a medial pathway, where anterior cingulate or insula is involved. This is responsible for the affective components of pain, the emotional reaction, and the attention to pain stimuli. And this pathway can be affected not from the tonic stimulation, but from the burst and maybe from high frequency stimulation. And why is this important? I found two interesting books. Swearing is good for you is one, and the second one, Black Sheep, the hidden benefits of being bad. So the researchers, the colleagues found that swearing reduces the pain. And they made some experiments and found out that some words, we can read the words, I don't have to read them for you, gave more or less pain relief. This is because pain is not only a biological phenomenon, it's actually a very much psychological phenomenon as well. So pain isn't a simple relationship between the intensity of a stimulus and the severity of our response, but circumstances, our personality, our mood, even the experience of previous pain, all of these things can affect the way we experience a physical hurt. So a provocative question is, can we rate the severity of certain words by how much analgesic effect they have? Another type of stimulation is this high frequency stimulation with 10,000 hertz or with 1,000 hertz. That depends on different companies. By this company, we have to place the leads in a very specific way, with one lead at T8, the second lead at T9. We have also this wireless spinal cord stimulation. What you can see here on this image is this receiver. We have to implant the lead or the receiver, but the patient has to wear this antenna over the lid with the help of a belt, and only then can have this stimulation. The advantage is that we don't have any big IPGs implanted. We don't have so many implants there. And the system is MRI, completely MRI compatible. The disadvantage is that the patient has to wear this belt all the time. So does the antenna, this wearable antenna, is always over these receivers. This could be a problem for many patients. The same leads can be implanted also subcutaneously under the skin. The principle is exactly the same. The leads are implanted, the patient has to wear this wearable antenna over these leads. We have patients with a hybrid stimulation. This is a combination of spinal cord stimulation and subcutaneous leads. Quite new is this closed loop stimulation. It's a new SCS system which controls stimulation dose by measuring the recruitment of fibers in the dorsal column and uses the amplitude of the evoked compound action potentials, these ECAPs, to maintain stimulation within an individualized therapeutic range. So we have a cycle. We start with capturing an ECAP, then compare the amplitude with a set point. We calculate a new stimulation current. We generate a new stimuli, and so on. Why is this important? Here, by this open loop stimulation, the traditional systems, you can see the stimulation. Here is the therapeutic window. When somebody is walking in place or sitting or coughing, you see that the stimulation is not always in this therapeutic window. So the pain relief is not optimal. In this closed loop stimulation, the stimulation is always, stays always within this therapeutic window.
The same general implantation techniques apply. Whether the pump is used to treat spasticity or chronic pain, the pump is implanted in the operating room under strict sterile technique. General anesthesia is preferable.
Which is needed. You see,
the lateral decubitus position allows access to the back and abdomen without the need to reposition and redrape.
This is the
pump is programmed by telemetry.
Programming device. We do it with telemetry. This is a pump from a specific
The pump comes with sterile water in the reservoir. This is removed before the pump is filled with medication. In the case of spasticity, it is baclofen. With chronic pain, the drug is usually preservative-free morphine. Ziconotide is also FDA approved for pain.
So
the lumbar incision is made to expose the fascia. A paramedian approach is used for the lumbar puncture, and an adequate length of catheter is advanced into the intrathecal space.
And this is the catheter comes in the intrathecal space. For pain, we can use only morphine and ziconotide as drugs, are the only approved drugs, and no combination of these drugs. So through the punction needle, the catheter is inserted.
The placement of the catheter is confirmed by fluoroscopy or X-ray. Satisfactory backflow of CSF through the catheter is ascertained before and after anchoring it to the fascia.
We remove the stylet from inside. We're looking for CSF in order to be sure that it is correctly placed. So CSF is coming out. With a series, we can.
The abdominal subcutaneous pocket should be made such that the pump is away from the rib cage and the iliac crest.
So this is the abdomen. We should prepare the place for the pump to come in.
The catheter is then tunneled to the abdominal pocket.
We should bring the catheter from the lumbar area to the abdomen front. And then the catheter should be connected to the pump. So in the end of the operation, catheter and pump are under the skin.
The catheter is connected to the pump, which is then placed in the abdominal pocket and secured to the fascia through a Dacron pouch or pump suture loops. The wounds are closed, and sterile dressings are applied.
So we have two types of pumps. We have the electronic pumps, there's a battery there, and we have pumps with gas. There are advantages and disadvantages. With these electronic pumps, we have to operate the patients every 7-8 years because the battery is not enough anymore. The advantage is that every time we have to adjust the doses of a drug, we don't have to empty the pump. We can do it with telemetry with a programming device. With the other pumps, who are gas pumps, we can leave these pumps in the body of the patient for more than 20 years. We don't have to operate again. But every time we want to have a new doses, we have to empty the pump and then refill it with a solution with a new concentration. At the level of the third neuron, we have the motor cortex stimulation, deep brain stimulation. These are big areas. I wouldn't say many things about these therapies. I would like to show only these pictures. The motor cortex stimulation is good for neuropathic pain and thalamic pain, usually after stroke. Usually we see that some months after the operation, the pain relief is not so good, and very frequently we have infections. And as last resort, we can do this deep brain stimulation, DBS, for neuropathic pain, phantom pain, trigeminal pain. We can stimulate the sphenopalatine ganglion as well. Here you can see a microstimulator and the codax of the lid, upper and lateral. So when the patient, this is thought only for patients with cluster headache. At this time, we are not allowed to make any more such operations. We're waiting for a new CE mark. The concept is that when the cluster headache patients are feeling that the attacks are coming, they should hold near this microstimulator a programming device and activate the system. Not very practical, but helpful. Every hospital or every department has its own algorithms. So by us here, we are looking if the patients have local pain, radicular pain, polyradicular pain, multifocal pain. When the problem is limited in one area, we can try with pulse radiofrequency or subcutaneous leads or a spinal cord stimulation. If the patient is not satisfied, if the pain is really strong, then we can try with a pump, intrathecal therapy. If that doesn't help, we can try with motor cortex stimulation or DBS. And if that doesn't help, then we have the ablative therapies. Patients with failed back surgery syndrome. This is the majority of the patients who are treating. And spinal cord stimulation. This is only a proposed algorithm based on the pain. If it is leg pain only, back pain only, combination of them, which is more severe, the back pain or the leg pain. There are many combinations. Today we have new systems, new IPGs with the capability to combine different waveforms. That means we can combine a tonic stimulation, for example, with high frequency stimulation, or tonic stimulation with burst stimulation at the same time, at the same patient. But every hospital and every physician has its own way, his own way of working. You all know that every patient is different, so our approach should be individualized. We always try to find the simplest solution, and simplest solution means not so many leads, not so many IPGs or pumps in the body. It is possible for the patients, for the majority of the patients, to have a very good pain relief, but they have to try all available options. And the physician should always be aware of this neuromodulation therapies, which can really help many patients. Not all of them, but many of them. We should be careful about this manipulation or exaggeration of these neuromodulation techniques, operations, or therapies. This is the Chocolate Museum in Cologne, in Germany, where I'm working. If you ever come in Germany, please visit this museum. So there I found this excerpt from COCO annual report. It talks about speculative manipulation and says here temporary price increases that are otherwise entirely unjustified and which has adverse effects on the solid real business as it used to be. So the bottom line is that we should not exaggerate when we plant leads or generators. We should always provide the minimum. The patient should keep in mind that there are many types of services and various combinations of therapies, but not all of them at the same time. They should choose. On the other hand, the physicians should keep in mind that they should make a decision. They should decide what is more important, the patients or money. But all these things, all these implants, the leads, the IPGs, the pumps are not so important. The most important thing is the teamwork. For this therapy, we need physicians, we need nurses, we need sales reps, psychologists, physiotherapists, neurologists, neurosurgeons, orthopedic surgeons. It is a teamwork. Only if we all work together, we can have surprisingly good results, as in this video.
Out of it either, it's anybody's race. Can anyone catch Milangeni? Oh, maybe somebody can. Is that our cameraman? He's matching him stride for stride. He's run the whole race with that camera on his shoulder. Just incredible. Milangeni will get the gold. The cameraman.
So the camera won. So we're active on social media. If you want, you can all follow us. As a member of the Public Education Committee of INS, I would like to invite you to our World Congress in May 2021 in Barcelona, in Spain. And as a consultant for social media and web content of our official journal, Neuromodulation Technology and the Neural Interface, I would like to ask you to follow us on Facebook, Twitter, and Instagram if you want to stay up to date about all new developments in the field of neuromodulation. So, thank you very much.
Okay, excelente, Georgios, muy comprensivo. Very well illustrated. I'm sorry, I'm speaking Spanish. Excellent, Giorgio. So let's open up for comments. I'm sure this is a new area of medicine for me, and probably a lot of the panelists too. So any comments or questions for the panel? Just unmute yourself and go ahead. Don't worry, Giorgio. Hello, Carlos.
Hello.
Carlos, could you please introduce yourself to the audience and to Dr. Georgios?
Giorgio, hello. My
Hello.
name is Carlos. I am from here, Spain, from Ciudad Real. Congratulations. I think the conference or the topics that you speak about that, and there's some very important things in the field of management of pain. My question is very shortly, what about the great occipital nerve stimulation on attention of facial pain?
The occipital nerve stimulation, so the placement actually of leads subcutaneously, noctum, can help patients with occipital neuralgia, but it could help also patients with trigeminal neuropathy, not neuralgia, neuropathy, or patients with not specific headaches. So this therapy is really good for a variety of diseases. It does not help always. We don't know why, but we have seen that many patients, usually women, benefit really from this therapy.
Do you have some experience, for example, in a cluster headache with great nerve occipital stimulation? What about if you are putting the tonic stimulation or bar stimulation? If and what time is indicated for these types of stimulation? If you have some cases that after 2 or 3 years of tonic stimulation, the change do it by stimulation, the pain is finally controlled, and after can we take it out the stimulator or not?
So let me start by saying that at least in this department, we are performing such operations, occipital nerve stimulation, for more than 20 years. My mentor, Dr. Koulouzakis, was and is still a pioneer in this field. So we have many such patients. First of all, the patients should try with drugs. If they cannot control the attacks or if the adverse reactions are really bad, then we can try with the leads. The results are really good. We have tried with tonic stimulation, the patients are satisfied. It seems to work with burst stimulation as well. Not by all patients, by many patients it works with burst stimulation as well. The patients are reporting a relief of more than 60 to 70%. Some of them have no pain at all, but they all keep the leads lifelong. Until now, we had no patients who said, we don't need the leads anymore, please take them out. We can take them out if there's an infection, and this is a problem. Sometimes the patients are coming to us with an infection, but there are no patients till now that they told us the pain is we don't have any pain, we don't need the system anymore. So actually they are married to this system for the rest of their lives.
Thanks. For the other side, for example, what is the difference in complications or risk rates between great nerve occipital stimulation and sphenopalatine ganglion stimulation? Because the two techniques we can use in the cluster headache treatment.
It depends on the type of stimulation you want to do. In the subcutaneous leads, the infection rate is higher. And also this area is very movable. That means the risk of dislocation of the lead is high. If we stimulate SPG, sphenopalatine ganglion, with such a microstimulator, then the infection risk is lower, and these dislocations are really rare. I don't know if you have any experience with PRF in sphenopalatine ganglion. We are not doing that here. This could be also an option without leads. And then you have naturally lower infection rates and no dislocations because you don't implant any leads in this area. But I must be honest, the patients who need such operations are difficult patients. All these patients with headaches or pain in different parts of the head are the most difficult patients we can treat. And very frequently, the psychological problems or factors play a huge role by these patients. This is why I'm not quite sure if we can really assess the success of these treatments, because a placebo effect is surely there as well.
Yeah, I think for these kinds of factors that will be influence the out of some therapy, it's important, and I think it's very important and essential to do before to decide for some kinds of neurostimulation therapies. We need to do a neuropsychological study to keep it out that some patients will be not really collaborate after the implantation of the device.
In some countries, this is a must. The insurance companies are not paying for it if we don't do it. They need this psychological or psychiatric evaluation before the implantation. And I think they're right.
Yeah. Thanks.
You're welcome. Thank you.
Well, you know, Carlos, we did a presentation on neuromodulation. Do you remember way back?
Yeah.
Yeah, and I'm going to show it to you. I'm going to show it to Georgios here. Yeah, let me just get you off the screen share there. Okay. Let's see. You see this presentation, Georgios?
Yes, I can see it.
Yes, I'll send you the link. Carlos did a couple of presentations on neuromodulation. One of them, baclofato intrathecal. Remember that, Carlos?
Yeah.
Yeah, it's a super therapy for spasticity. Super therapy.
Yeah. I was beginning my study and my preparation in the neuromodulation techniques in Pécs in Hungary in 1998, and after that I doing Parkinson therapy, and after with chronic pain management, and doing at this time all kinds of neuromodulation techniques. For example, I have one patient with cluster headache treatment that who was in a very bad situation with all kinds of therapies that not will be a good results. He was decided to murder him, but we used a great nerve stimulation, and we controlled the pain for this patient after 2-3 years. And after that, the patients did not need it to do any stimulation. We just stopped the activity, or we stopped the function of the IPG, and the patient at these times we have 6 years of follow-up. The patients don't need the stimulation again. So maybe I think in some situations maybe alterations in the function of some nerves may be changed after the stimulation. I think so. For example, in so many cases we can treat to use for the nerve stimulation in occipital pain, sure, but in the trigeminal neuralgia too, maybe we have good results. I think, for example, in my opinion, I know that the subcutaneously implanted devices have a higher possibilities to migration. But if you are doing a good fixation at the fascia, I think we don't have any kind of possibility to migration. But I think in my opinion, the subcutaneously placed electrodes will we have a little lesser complications rates than as sphenopalatine stimulation. I think this is just my opinion.
There's no right or wrong here. We have to see, we have to follow these patients up for many years. 6 months or 12 months are not enough. We have to see what's going on after 5 or 10 years by these patients.
No. We have more than 6 years of follow-up.
Okay. It's really, really interesting, and I agree there are patients who don't need the stimulation anymore after some years. I have never seen it with patients with cluster headache or occipital neuralgia. I have seen it by patients with back and leg pain. I don't have an explanation, but I assume that this neuroplasticity plays a huge role. This spinal cord stimulation, for example, is altering the connection of the neurons, and maybe some patients are really lucky, and after some years they don't need the device. But this is the exception.
Yeah, it is very, very, I think, a very few rare cases, but these cases will keep for us that thinking what about really effect of this kind of devices.
I agree.
Thanks.
Hi, Marlena. Do you have any questions or comments?
Congratulations, George. Really enjoyed the presentation.
Okay,
just that I'm excited to learn about this stuff, nothing more. Thank you.
Thank you, Marlena. We have a few new arrivals. Michaela Pongan, could you please introduce yourself? And if you have any questions, you're welcome.
George. Hi, everyone.
Hello.
Congratulations from my part as well. I'm very impressed about your presentation. I'm a neurologist in Romania, adult neurologist. And as I know until now, in Romania, there is nobody interested in this field in the neurology and in the neurosurgery. And I'm very interested because I'm being a neurologist. I'm interested in chronic pain. I'm treating pain with botulinum toxin. I'm injector. I'm treating with medicine. And this field is new and very interesting. And I am very impressed about all the information I heard here today. I'm very impressed. Again, congratulations. Excellent.
Thank you very much. But you know already that you can visit us here in Cologne and see for yourself what we can offer.
Thank you for your invitation. I will. Thank you.
Making connections here. Yeah. That's great. Dr. Al Hussein, welcome. And please introduce yourself. And if you have any comments or questions.
Thank you. And hello, everyone. I am Ahmed Hussein. I'm working in North Germany in Diaco Hospital in Flensburg at the border with Denmark. Thank you for your lecture. It was very interesting. It is complex subject, neuromodulation, and I think we are just at the beginning of neuromodulation. We need to make more experiments, more research to understand which patient actually the suitable for such procedures. We don't understand why neuromodulation by, for example, in occipital neuralgia, sometimes it works, sometimes not. And I think what you are doing now in Cologne is very interesting. I heard about the new things today, and I would like to read about everything. And I try now to make neuromodulation in my hospital in Flensburg. And I am very grateful for this lecture, and thank you for this job. And maybe we will meet someday in Germany. Thank you very much.
You are also very welcome to join us here to see what we are doing.
I would happily join you. Thank you.
So I think what we really need are guidelines, algorithms, and a registry for all implants, so that we have an overview of what we are implanting, who is implanting, and what is the outcome after some years after the implantation.
Thank you very much.
We have an aspiring neurosurgeon here, Marco Antonio. Marco, are you there? He's about to enter his residency, I believe. Marco, can you hear me?
Yes.
Hey, Marco, please introduce
Hi,
yourself.
everybody. Well, I'm Marco Antonio. I'm from Bolivia. Also, thank you for this lecture. It's very interesting. Also, Carlos, he presented another lectures about the same topic, and it's very interesting. Everything. Thank you for your time, Professor Georgios.
I'm not professor, but thank you for being here with us.
Yeah, welcome, Marco. You know, low back pain is the most common medical problem in the world, and any progress against that is welcome. What area of neurosurgical problems has made the most progress? Would you say what area has a neuromodulation made the most progress? What type of problem?
I would say the lumbar pain, because up until now we could effectively treat patients with leg pain after an operation in the spine, but these lumbar pain patients were always a challenge. It was difficult to offer a very good pain relief in lumbar area. Mm-hmm. Now, with these new types of stimulation, the new waveforms, and the combination of these waveforms, we have much better results. We have many lumbar pain patients who are satisfied, and this is with spinal cord stimulation therapy, and this is the reason why we don't implant so many subcutaneous leads anymore, and this is the reason why we don't implant so many pumps by these patients, because they are satisfied with spinal cord stimulation. And this is a great advantage, because the patients do not need any drugs, and they don't need any opioids, which is, as I know, a huge problem in the United States, and maybe it's going to be here in Europe as well in a few years.
Yes, I was going to mention that. Low back pain causes a lot of creation of addicts in this country anyways, because people get hooked on opioids, and they have a worse problem than back pain after, during treatment. So let's see here. George, any comments or questions of Georgios? George Carmani? Perhaps not. Can you hear me okay, George?
Yes, of course, I can hear you.
Oh, okay.
Okay, thanks for the very informative presentation, Dr. Mathis. No, it's a quite exciting area. This neuromodulation field. I have been working almost over 12 years now, and in the medical industry, and the cases and the patients we treat are really, we have been having always better results and better outcomes, and the patients become very satisfied, and for me it's quite exciting working in this field, and I encourage you all to try by selected cases, of course, this type of therapy.
You know, Georgios, do a lot of patients come to you, they've tried everything else, and they say, well, I'm going to try neuromodulation? Or do any patients come to you the first time, they haven't tried anything and they want to try neuromodulation? You probably don't get many people like that, right?
I don't get many people like that. I
Yeah.
really often get people that they have pain since 15 years, and they told, I found something in internet, so I came to you. So for me, it is surprising to see that these patients are not referred to us from the colleagues, from orthopedic surgeons or neurosurgeons, and the patients themselves find this solution to their problem.
Right.
But I must say that our operations, our therapies, do not work so well when somebody is having pain for 15 years. So the sooner, the better. Of course, one should try with physiotherapy, with drugs, this is for sure,
Right.
but should not wait 15 years for another option.
Right, right. By the time that they're hooked on narcotics, yeah. So there's not many people who just show up and say, oh, I guess during residency, maybe Carlos, if he's still here, are the residents exposed to neuromodulation, a neurosurgical resident or neurologist? Are they exposed to it during residency? Does anybody know that? No, I guess no one knows.
I guess no.
No?
I guess no. In Germany, we have, or in my hospital, we have this privilege. We have two separate departments, department for general neurosurgery and department for stereotactic and functional neurosurgery. And the residents of the general neurosurgery are spending 1 year with us. So they learned our therapies, and at least they know what it's all about. And most of them can perform some of our operations when they are gone. But in all other hospitals, I say that the colleagues are not seeing, they don't see anything, and most of them don't know anything about neuromodulation.
But a neurosurgeon could easily pick it up. They could easily learn it, obviously.
Everybody can easily learn it.
Yeah.
Not only the neurosurgeons.
Okay. Do you find, I guess that's probably the biggest users of your neuromodulation, right? Neurosurgeons? But second, neurologists?
It depends on the country. In Belgium or in the Netherlands, the anesthesists are the majority who are performing.
Oh, wow, the anesthesiologists.
In Germany, it's the neurosurgeons.
Okay. Yeah, in this country, yeah, the anesthesiologists handle a lot of pain patients. They seem to handle a lot in this country. I don't know what.
But in the United States as well, if you make a search in the social media, you will see mainly anesthesiologists who are performing such operations, not neurosurgeons in the United States. But a neurologist could do that. For example, our colleague from Romania, an anesthetist can do it, a neurosurgeon can do it, an orthopedic surgeon can do it, a cardiologist could do it for patients with angina pectoris, or a vascular surgeon could do it for patients with peripheral arterial occlusive disease. So it's not only for neurosurgeons, it's for the whole medicine.
Oh, is it the same way in Spain? In Spain, Carlos, same thing? Neuromodulation, it's mostly done by neurosurgeons, or who?
I think in the last time the anesthesiologists can gain the field of neuromodulation in pain, but not all of them. Some kinds of techniques of neuromodulation for pain is exclusively for neurosurgeons, such as motor cortex stimulation, debris stimulation is as exclusive for the neurosurgeon. The anesthesiologists don't do that. But the laser neuromodulation techniques such as spinal cord stimulation, peripheral nerve stimulation, subcutaneous stimulation is do it for anesthesiologists. And in the last time they are gaining this field. It's important to see to punctuality that we need to know what's about the neuromodulation, as the neuromodulation field is an extensive area, and there will be neuromodulations for movement disorders, neuromodulations for psychiatric disorders, and neuromodulations for pain. And at this time, we speak just about neuromodulation for pain. In the neuromodulation for pain, I think in the world, so many specialists doing, such as anesthesiologists, neurologists, orthopedic surgeons in some care, and anesthesiologists and neurosurgeons. But I think in a near future, the anesthesiologists will dominate this field because, for example, in Spain and in Hungary, the specialization after the general medicine is, for example, anesthesiologists and professionals in controlling pain. These devices had the diploma having the people, but we need to know that what is the experience about that. If every centers will have enough resource to do these kinds of techniques. I think such as, for example, the neuromodulation for movement disorders and or psychiatric disorders is to concentrate in some centers, but maybe, for example, in Hungary, there will be just 4 centers for neuromodulation techniques, because we need to concentrate the patients to one center. It is important because the people or the professionals who are doing this kind of techniques will have more patients, more experience, and more good results, I think.
Mm-hmm. How about Dr. Chirag, in India, have you seen much of neuromodulation around?
Yeah, actually, in few of the institutes, like premier institutes in India, like AIMS and NIMHANS, I've actually done from NIMHANS neurosurgery. So in this couple of institutes, we are doing deep brain stimulation for movement disorders at least. Not that frequently for pain and pain problems like spinal cord stimulation and DRGs and all those things. But at least in 2 or 3 institutes in India, we have exposure to deep brain stimulation for movement disorders, as well as psychiatric disorders in these institutes during residency. And considering the pain part, actually in India, majority of the pain treatment, pain injection techniques and neuromodulation at a few centers where it is being done, usually it is done by the anesthesiologist here. Actually, to Dr. Georgios, I wanted to ask you a couple of questions.
Go ahead.
Yeah, one question is regarding intrathecal drug delivery for spasticity when you're using baclofen for that. So what exactly is the usual location of the placement of the catheter when you place it? Because see, most of the patients, when we consider baclofen intrathecal drug delivery, they are spastic quadriparetic patients. So if the placement of the catheter is in the lumbar region, then the upper limbs many times don't get the same benefit as lower limbs. So what is your take on that? And what exactly is the safest, highest position where you can place the catheter?
Very good question. There is no answer. But
okay.
we should say this thing. Baclofen is a hydrophilic drug. Yeah. This means if you apply it intrathecally, it's going to move upwards from along. Okay. That means that the placement of the catheter is not so important as with other drugs which are lipophilic. Okay, but you're right. If you have a patient with spasticity in the legs and in the arms, you have to decide about the tip of the catheter. By patients with spasticity only in the legs, we would place the tip of the catheter at T10, T9, somewhere there, and they are satisfied. The challenge are the patients with upper limbs spasticity, arm spasticity. There I would place the tip of the catheter at T4, T5. I wouldn't go any higher than that. And according to our experience, even if the tip of the catheter is higher than T4, or in the cervical area, we had patients with dislocations of the catheters, and the tip landed at C4 or D5. The spasticity in the arms was still not so good not good treated as the spasticity in the legs. But if we could choose for arms, T4, for legs, T8, T9 maximum.
Okay. And one more question is regarding spinal cord stimulation. What is your take on spinal cord stimulation for spinal cord injury related paraplegia?
It is experimental. Everything is experimental at this point. There are some centers in Switzerland. In the United States, they are intensively working on this field, but it's not the work of a neurosurgeon or orthopedic surgeon. It's a team with biomedical engineers, a very intensive physiotherapy or rehabilitation. And I think that this intensive rehabilitation plays a huge role in this disease. Neuromodulation could help, but I'm not quite sure that neuromodulation is the key player here. But once again, because there are patients who are asking about that, who heard about, it's still experimental. We cannot offer this therapy for this indication.
And before placing this baclofen pump, what is your protocol which you follow there for the trial dose of baclofen?
20 years ago, we did a trial. We gave a bolus of 50 micrograms baclofen and waited to see what happens. If the patient had no improvement, the next day, another bolus, 75 micrograms. If no improvement, the next day, 100 micrograms.
Okay.
If no improvement, 150 micrograms. And we stopped there. We saw that all patients, or 99% of the patients with spasticity, had a very good end result. So since 10 years now, we don't do any trials. We do only one operation. We implant the catheter and the pump at the same time.
Okay.
This is naturally not the same case for pain patients. This is completely different. But for baclofen patients, we don't do any trials.
Okay. Yeah. Thank you very much, Georgios. And actually, that was a wonderful presentation. Actually, I've learned quite a lot of things from the presentation. And I would also be interested to join you and take some experience at your institute.
You are welcome.
Thank you very much.
You're welcome. Thank you.
Yeah, we look forward to following what you're doing there, Georgios. So whenever you have something, whenever you have something you think may be a value to the neurosurgical community, just let me know, and we'll just we'll do some more. And that applies to everybody. If you have something that you feel will contribute to the knowledge of neurosurgery, just let me know. We'll put you on the air and have you give a presentation. Okay. So we thank you. This will be recorded. Let me just do a little self promotion. We have another broadcast in a couple of hours for a couple of neurosurgical students or residents from this gentleman's from Morocco. He's going to talk about acute intervention of spinal disease. And then this student is at Harvard doing a fellowship. He's a medical student from Cameroon, Ulrich. He's doing research for future African neurosurgeons. So a little plug. We're getting like TV, Georgios. We thank you all for coming. And I'm going to stop recording, and you can hang out and just network. So thank you very much.
Thank you very much.
Okay, we stopped recording it. So yeah, that went well, Giorgio.
I hope it was interesting.
Well, you know, I'm like a lot of people. We heard of it, but don't know what it is. So hopefully that'll answer some questions of people that are watching. So, anyways, so are you involved in the research or basically patient care?
It's only patient care and bureaucracy.
Oh, bureaucracy. Yeah, that takes time.
We're trying to drag him into research, though.
We're
trying to involve him. But
okay.
Not too much time for him, unfortunately.
Oh, Marlena, are you in research?
Yep.
Oh, really? What are you doing? What kind of research are you doing regarding neuromodulation?
Well, not modulation, but hopefully with the help of George, we can involve neuromodulation in our research. It's a spinal cord injuries and investigation of circumstances and therapies and.
Well, would you like to give a presentation on what your findings of your research? Because you're welcome to do one if you want.
Thank you very much. I'm not the coordinator, so I don't think I should be doing the presentation. I'm just a part of a team, but it's a good work.
Okay, let your team know that if they want to broadcast what they're doing and let the world know, we'll be glad to do it.
Well, thank you very much.
And Dr. Chirag, this is your first time, right?
Actually, it is for the second time. Actually, if you remember earlier when I was there in Oxford.
Oh, okay, that was a while back, right?
Yeah, it was way back.
Okay, yeah, you're welcome. And Dr. Al Hussein, you're welcome too at any of these. If you're on the mailing list, you'll get notices of webcasts, and there's always a link in there, so you can just jump in if you want. And we also have an app now, Neurosurgical TV app, where that show was live. It was on the front page of the app, so it's easy to access from your smartphone. You just download the app and tap, and you come right into the webcast, like you are now. Like I can see Marlena's from a smartphone, so she could have come in right from her smartphone, boom, boom, tapping, and not, typing is a pain with a smartphone, but if you can tap, you're on the right direction. So. Anyways, okay, very good, everyone. Thanks for coming. It's going to be on Neurosurgical TV recorded if you want to watch it. So, and I thank you, Georgios, for the time and the effort.
Thank you for the invitation and the opportunity.
Okay, very good. Okay, everybody, have a great day.
Have a nice weekend.
Thank you.
Bye-bye. You too. Bye.
Bye.
Thank you. Bye-bye.